And you should be good.
Okay.
Yeah.
Well, thank you
And then
everybody
remember
for
the second thing, right? So once you're
joining.
recording,
Oh, you don't have to do the title or anything because
So we're
we're
done?
not streaming. That was
Okay.
basically just a slate
okay, so we're good to
for
go now.
so people who join early to this thing don't have to see you guys running around.
Gotcha.
beforehand and stuff
Okay.
Like that.
Okay.
We're good to start? Okay. Okay, thank you everybody for joining me today. My name is Sue Fei. I'm a PGY3 in the Sport and Exercise Medicine program at the University of Toronto. And today for my journal club, I will be presenting on an overview of femoral acetabular impingement, also known as FAI, with a couple of articles at the end talking about hip arthroscopy. Sorry, how do I go on to the next slide?
Should just be able to press over.
Okay.
Just press over every single time.
So this group from Switzerland, Gans et al., popularized the concept of FAI based on in situ inspection of 600 dislocated hips. They theorized that it is as a result of abnormal contact that may arise as a result of either abnormal morphologic features involving the proximal femur and or the acetabulum, or as a result of subjecting the hip to excessive and supraphysiologic range of motion. Sankar et al. In 2013 expounded on this definition and described 5 essential elements to FAI, including abnormal morphology of the femur and or the acetabulum, abnormal contact between these two structures, vigorous supraphysiological motion, repetitive motion, as well as presentation of soft tissue damage. So a group of international experts came together and came up with the Warwick Consensus Statement on FAI, published in 2016. So they define FAI syndrome as a motion-related clinical disorder of the hip with a triad of symptoms, clinical signs, and imaging findings. It may represent the symptomatic premature contact between the proximal femur and the acetabulum. And the level of agreement on that was 9.8, with 10 being complete agreement on a 10-point Likert scale. So from all these definitions, there are some key terms that are emerging. So we now recognize FAI as a clinical syndrome with features of abnormal morphology of the hip, abnormal contact, supraphysiologic stress, repetitive motion, all leading to soft tissue damage. We now know that there is an association between FAI and early OA. The concept that abnormal morphologic features of the hip leading to OA is not entirely novel. In 1975, just to provide some historical perspective, this group, Stolberg et al., characterized pistol grip deformity in patients presenting with early OA. We also know that DDH causes abnormal loading at the anterosuperior hip, leading to OA. FAI concept was essentially introduced to account for early OA in young patients who do not have overt history of hip dysplasia. From longitudinal population-based studies, we know that people with Cam deformity are at increased risk of developing OA. However, the presence of Cam itself does not lead to clinical OA. And for now, there is insufficient evidence to confirm that there is similar association between the Pincer deformity and development of early OA. Cam deformity refers to an abnormality of the femoral head. Essentially, the femoral head loses its spherical shape, and in hip flexion, it abuts against the acetabulum. It is more common in young athletic men in their 3rd decade of life. Here are some pictorial representations of the CAM mechanism. So essentially, with hip flexion, you have the CAM bump compressing against the cartilage, which causes the cartilage to displace medially, displace centrally because of the shearing stress. The cartilage can also separate from the subchondral bone and the labrum. There can be damage to the labrum as well in terms of undersurface tear, but the labrum itself remains attached. Cam deformity can be a primary variant at the head and neck junction. It can also arise from a variety of secondary causes, including subclinical SCFE, residual childhood diseases, including Perthes, post-trauma, such as femoral neck fracture, post-surgery, such as periacetabular osteotomy, as well as rare cases of tumors of the proximal femur with case reports of osteochondroma, osteoid osteoma presenting as a FAI syndrome clinically. So the Pincer deformity is an abnormality of the acetabulum in terms of either general or focal acetabular overcoverage. And because of this, there is abnormal contact between the acetabular rim and the femoral head and neck junction. And this is more commonly seen in middle-aged women, occurring around age 50. Here are some pictorial representations of the Pincer mechanism. This causes primarily a problem with the labrum. So with hip flexion, there is compression between the Pincer impingement against the femoral neck, causing damage to the labrum. Over time, there can be heterotopic ossification of the labrum, leading to worsening of the Pincer impingement. The depth of articular cartilage damage with the Pincer deformity is not as severe as that seen with a Cam deformity, and it is more common at the rim as opposed to the more centrally displaced location as seen with a Cam mechanism. We typically think of Pincer deformity in terms of general acetabular overcoverage or focal acetabular overcoverage. Essentially, with general overcoverage, you have a deep socket in the forms of coxa profunda or protrusio acetabuli. With focal coverage, with anterior focal coverage, focal overcoverage, you have a cranial acetabular retroversion, which manifests radiographically as crossover sign or deficient posterior wall. You can also have posterior overcoverage, and this will manifest radiographically as an excessive posterior wall. So here are some radiographs representing different variations of the two variations of a deep socket. So with coxa profunda, the floor of the acetabular fossa either touches the ilial ischial line or is medial to it. With protrusio acetabuli, the head of the femur is medial to the ilial ischial line. With anterior overcoverage or acetabular retroversion, you will check for the crossover sign where the anterior wall crosses over the posterior wall. You can also check for the posterior wall sign where the posterior wall is medial to the center of the femoral head. When normally this line, the posterior wall, should run through the center of the femoral head. In order to diagnose FAI, you need to take a good clinical history of the pain. FAI pain is typically described as presenting in the deep groin. There can also be overlap with pain in other areas, such as trochanteric, buttock, sacroiliac, and patients may come in describing the C sign as well. The onset, most commonly reported, is insidious. Some may attribute the pain from a traumatic event. The character is usually described as a deep intermittent discomfort that is activity related. There can be mechanical features as well, and a hallmark of FAI is that it is aggravated by deep flexion, such as prolonged sitting. You also want to take a good history of previous hip problems to screen for secondary causes of FAI deformities. In terms of impingement testing for FAI, you can do the FADIR test, which is hip flexion, hip adduction, and internal rotation to check for anterior impingement, and this test is positive if pain is elicited. I should say that although this test is sensitive, it is not specific for anterior impingement. You can also put the hip in external rotation and in extension to check for posterior impingement. This maneuver can also elicit pain in the anterior compartment, such as the anterior labral tear, because when you do this maneuver, the head of the femur is also translated anteriorly, and this can cause entrapment of an anterior labral tear. So all in all, no physical exam maneuver is pathognomonic for FAI, and you do need the whole clinical picture to make the diagnosis. One of the hallmark of FAI on physical exam, I didn't include a slide on this, but I thought I'd touch on it, is loss of internal rotation. Although this is true, patients with FAI do not necessarily have to have a loss of internal rotation, and certainly people with reduced internal rotation do not necessarily clinically present with FAI. Diagnostic imaging supports the diagnosis of FAI in a symptomatic patient. This is important to remember because from radiographic studies done, or imaging studies done in asymptomatic volunteers, there can be a high prevalence of deformities associated with FAI, whether it is Cam or Pincer, with numbers reported between 10 to 20% usually in the study. So just because a patient has radiographic evidence of FAI, if they clinically do not present that way, then you cannot diagnose that patient with FAI syndrome. Plain films are helpful to support the diagnosis. You can order a number of views. Typically, you need an AP pelvis. There are a number of lateral views. So shown here are cross-table lateral in the top middle, 45-degree done view just right to the right of it, and to the bottom left you have the 90-degree done view, and in the bottom middle section you have a frog leg lateral, and the one on the bottom right is a false profile view. Essentially what we're trying to do with ordering all these different views is to try to capture a 3D deformity with different projections of 2D images. With the false profile view, that can be helpful in assessing for anterior acetabular overcoverage. Alpha angle is commonly used to quantify a Cam deformity. So this is where you draw a line through the center of the femoral neck, passing through the center of the femoral head, and you draw another line going from the center of the femoral head to a point on the femur where the femoral head loses its circle shape, its sphericity, and that angle formed by the two lines is the alpha angle. Numbers over 50 is typically associated with FAI. The lateral center edge angle is used to assess superlateral acetabular overcoverage. For this one, you have a line going through the center of the femoral head that is perpendicular to the transverse pelvic axis. You have another line going through the center of the femoral head to the superlateral point of the weight-bearing region on the acetabulum, and the angle formed is the central or the lateral center edge angle. And there is some ambiguity in terms of what values are associated with FAI, but I've seen values between 30 to 40 reported, anything over than that being associated with FAI. Cross-sectional imaging is useful in FAI as well. CT with 3D reconstruction helps to define the bony morphology, which is helpful in surgical planning. MR arthrogram is seen typically to be superior to MRI and is more commonly used. It is better at detecting acetabular labral tears, as well as intra-articular pathology. The important thing to note with MRA is that with the increased sensitivity, you can also have higher numbers of false positives. Management for FAI is classically divided into non-surgical versus surgical. There is not a whole lot of evidence in supporting one over the other. In someone with chronic hip pain presenting like a FAI syndrome that's been stable, it is certainly reasonable to start with a trial of physical rehabilitation. The physiotherapy protocol for FAI is not standardized. Different physiotherapists may try to improve different things such as neuromuscular control, strength, range of motion, or stability of the hip. Surgery can be done in either with either open dislocation or an arthroscopic technique. Showing the pictures there are just some arthroscopic images taken intraoperatively for resection of a Pincer deformity. The 3D reconstruction shows the before and after images of the surgery. Here is a flow chart just to summarize our kind of diagnostic decision making around FAI. So you need to make the diagnosis, you need a triad of symptom signs as well as radiographic evidence of FAI, and after you make the diagnosis, you have a discussion with the patient to talk about treatment options, which can include conservative care, physical rehabilitation, or surgery. So the first article I will review today is a fairly recent trial done in June of last year, comparing hip arthroscopy versus best conservative care for the treatment of FAI. So this is a pragmatic multi-center assessor blind randomized control trial that was done at 23 hospitals in the UK. You can see the inclusion and the exclusion criteria here. To summarize, people clinically have FAI with hip pain and radiographic features of Cam or Pincer deformity. They're 16 years of age or above. They excluded patients that have moderate to severe hip OA, a history of hip pathology, or a history of previous shape-changing surgery of the hip. So this is table 1 from the study looking at baseline demographics of the population. So the average age is around 35 years. More men were enrolled than women. The average duration of hip impingement is around 3 years. Also like to point out that there were predominantly more Cam deformity or Cam impingement type in the study than pincer or mixed. So the intervention is hip arthroscopy that was done by a senior surgeon. There were 27 surgeons that participated. They treated shape abnormalities, labral or cartilage pathology, basically anything that they deemed that was indicated to be treated. The patients were discharged home when they were able to walk, typically within 24 hours. They had outpatient rehabilitation following surgery. MRI was obtained at least 6 weeks post-arthroscopy. Fidelity of surgery was assessed by this group of international experts using operation notes, intraoperative images, and post-op MRI. Comparison group is what they call personalized hip therapy, which is physiotherapy-led rehabilitation. It is what they consider to be best conservative care for FAI syndrome, with 4 core essential components, including an assessment, patient education, exercise program that was taught in clinic, followed by a home exercise program with features of individualization, progression, and supervision, as well as pain relief management. There were 47 physiotherapists that formally trained at this one-day workshop. There were 6 to 10 follow-ups, patient follow-ups over this 12 to 24-week period. Fidelity of the treatment was also assessed, and it must include all the core components, and that physiotherapy must be individualized, supervised, and progressive. Here's a flowchart of the participants that went through the study, just pointing out that around 170 patients were in each arm of the study. There's about 27 patients in the hip arthroscopy group that actually didn't get a chance to have the intervention, and I think it says 14 patients, sorry, the font is a bit small, in the therapy group that actually crossed over to the arthroscopy group later to have hip arthroscopy. And they did an intention to treat analysis on all the patients that were enrolled in the study. So the primary outcome in this case is hip-related quality of life, measured by this IHOT-33, which is a validated tool. They also had secondary measures of health-related quality of life, adverse events, as well as healthcare resource use. These outcomes were collected at 6 and 12 months after treatment allocation. The positive finding that they had from this study was in terms of benefit in favor of hip arthroscopy for the primary outcome at 12 months, with a difference of 6.8 on the scoring system between hip arthroscopy and personalized hip therapy. A score of 6.1 was what they deemed to be clinically significant. So this finding is both statistically as well as clinically significant. There was no significant finding in terms of secondary measures of the various health-related quality of life scores. Here's just a graph again showing the positive outcome in the primary outcome between the two groups, favoring hip arthroscopy at 12 months. In terms of adverse events, it is not surprising that there was more adverse events, certain adverse events that were reported more commonly in the hip arthroscopy group, such as superficial wound problems. There was also a case of hip infection in the hip arthroscopy group with a patient later needing a hip replacement. One limitation of the study is that people waited longer to have treatment in the hip arthroscopy group versus the therapy group, which is not unexpected. Is just one way in which the study may not be balanced. And also the outcome was measured at 1 year post-allocation as opposed to post-treatment. So some of these people literally had their outcomes measured days, weeks, a few months after their hip surgery, so it is not necessarily reflective of the long-term outcome. Another limitation, again, is in the fact that they only had data at 1 year as opposed to more long-term outcomes. Most of the patients in this study had Cam Deformity, which was shown to have a positive outcome when it was kind of arthroscopically corrected. Because of the low number of patients with pincer or mixed type morphology, it's hard to say whether the same benefit extends to this group of patients. And also, you cannot entirely exclude that there's some sort of placebo effect because you can't really blind, well, they didn't blind the patient in this case who had the procedure, say, with something like a sham treatment, so there might be some placebo effect expected there. So the second study that I'm going to review, the title is a bit cut off, but essentially it was looking at outcomes at a 2-year follow-up following hip arthroscopy, again for FAI. This is an older study in 2009. The reason I picked this study is that it actually looked at predictors of outcome post-hip arthroscopy, and there aren't many studies that do that yet. So the population in this study is composed of 125 prospectively enrolled patients who underwent hip arthroscopy by this single surgeon for FAI. Similarly, clinically, they had hip pain and radiographic diagnosis of FAI. They were also similarly excluded, just like the previous study, if they had a history of AVN or previous hip surgery, or if they had bilateral hip arthroscopy. So the mean age of patient in this study is a little bit older, around 40, and there's actually more women than men that are enrolled, albeit this is a smaller study. So there's the intervention in this case is essentially arthroscopy. The surgeon went in there and did what he deemed to be indicated. This could be resection of the cam and or pincer deformity, chondroplasty or microfracture, depending on the severity and the type of the articular lesion. He also did debridement of degenerative labral tears and repaired labrum where it was necessary. Questionnaires, self-administered questionnaires were done pre-op as well as at 2 years post-op, looking at various hip-related outcome scores as well as patient satisfaction on a 10-point scale. So here are the results. They are essentially all positive for the hip-related scores when you compare post-op score to pre-op. The predictors of positive outcome were when they had a less favorable pre-op score, more joint space narrowing, or if the patient had labral repair. The major limitation of the study is that there is no comparison group. They also included hips with degenerative changes and did surgery on that, so it's difficult to say whether the outcome is strictly attributed to resection of either Cam or Pincer deformity. All the procedures were done by a single surgeon, so that limits the external validity of the findings and the generalizability of the findings. The outcome scores in this case were not validated, and again, there's no long-term data beyond the 2 years. So definitely, we've found, we've been learning about FAI, and there's still very much to learn in the field of FAI with many questions to be answered. We don't really know how Cam or Pincer morphologies develop. There's a theory that childhood sporting activities may increase the risk of FAI. That remains to be elucidated. We also need to clarify on better radiographic values that better support our diagnosis. As well, impingement morphology, we know, does not necessarily lead to secondary joint problem. So we need to better characterize exactly what specific characteristics of FAI, what are the positive predictors that will tell us more in terms of which patients will develop OA later on. With the first study, the Cam, people with Cam FAI did better with surgery than people with Pincer, although there weren't that many people with Pincer morphology. So more study is needed along these lines to tell us which characteristics of FAI will predict benefit from treatment. Currently, there is no evidence suggesting that treatment for FAI will prevent hip OA, so long-term data are needed to see if these people that had either surgery or conservative management will end up developing hip OA. So that is the end of my presentation. Thanks, everybody. Okay.
Stop recording.